In the series of ECG Basics, today I will talk about R wave. First is the disclaimer. Caring Doc's YouTube channel does not provide medical advice. Information available on this channel does not offer diagnosis or advice regarding the treatment. Information provided by this channel is for educational purpose only, and it should not be used as an alternative to healthcare professionals' diagnosis or treatment of any person or animal. Please seek the help of medical expert for diagnosis, prevention, and treatment of medical illnesses. There is no endorsement for any brand or a company. R wave is the first upward deflection after the P wave. This represents the early ventricular depolarization. There are three different types of R wave abnormalities. We see dominant R wave in V1, dominant R wave in AVR, or we can see poor R wave progression. The dominant R wave in V1 are seen in they may be normal in children and young adults, right ventricular hypertrophy, pulmonary embolism, persistence of infantile pattern, left to right shunt, right bundle branch block, posterior myocardial infarction, Wolff-Parkinson-White syndrome type A, incorrect lead placement, that is V1 and V3, they are reversed, Dextrocardia, hypertrophic cardiomyopathy, dystrophy, myotonic dystrophy, Duchenne Muscular dystrophy. Here we can see the ECG of 2 years old child, and this is normal ECG with dominant R wave in V1. Similarly, here we can see this is this ECG is also showing right ventricular hypertrophy. We can see dominant R wave in V1. Similarly, here in this ECG, this is right bundle branch block ECG. Dominant R waves are seen in V1. Posterior MI, here we can see dominant R wave in V1. Wolff-Parkinson-White syndrome, dominant R wave in V1 with delta types of the R wave, means slight sloping of the initial portion of the R wave is seen. Here we can see lead V1 and V3 are reversed. As we know that biphasic P waves, they are typically seen in V1, not in V3. This is a ECG of muscular dystrophy patient. Here we can see prominent or dominant R wave in V1. The condition where dominant R wave in AVR are seen, it is because of poisoning with sodium channel blockers like TCAs, Dextrocardia, incorrect lead placement, left and right arms they are reversed, commonly elevated in ventricular tachycardia, poisoning with sodium channel blocking drugs causes a characteristic dominant terminal R wave in AVR. Poisoning with sodium channel blocking agent is suggested if R wave height is more than 3 mm, R by S ratio is more than 0.7. This is the ECG of a dextrocardia patient. Here we can see positive QRS complexes with upright P wave and P and T waves in AVR, negative QRS complexes with inverted P and T wave in lead V1, marked right axis deviation, absent R wave progression in the chest leads, that is dominant S wave throughout. Here the left and right arm leads, they are reversed. It is one of the most common cause of the dominant R wave in AVR. It is because of incorrect limb lead placement with reversal of the left and right arm leads, and this produces a similar pattern to dextrocardia in limb leads but with normal R wave progression in the chest leads. Whenever there are left and right arm leads reversal, the lead 1 becomes inverted, lead AVR and AVL switches places, and lead 2 and 3 also switches their places. This is a ECG of a patient with ventricular tachycardia. Coming to the poor R wave progression, that is the third R wave abnormality. The poor R wave is described when the amplitude of the R wave is less than equal to 3 mm in V3, and it is usually seen in prior anterior septal MI, left ventricular hypertrophy, inaccurate lead placement. It may be a normal variant. The R wave progression, poor R wave or absent R wave progression, it is also seen in dextrocardia patient also. Dr. Frederick Banting has said, if you really want to do something, you will find a way, and if you don't, you will find an excuse. Thank you. With this, I conclude my today's topic. Keep learning.